Let's get started. I don't want to get into the details in this session for the indications, the prognostic value of CPET, and the algorithms that we can use sort of to give exercise prescriptions, lung resection surgery. Those are things that I'll cover in either session 2, or if we can't cover in the cases, then we'll have to have a third session going over prognostication and utility of CPECs. But just to suffice this to say that there are 2 major class 1 indications by the American Heart Association. First is to evaluate exercise capacity and response to therapy in heart failure patients. So whether you put them on a heart failure medication and you want to assess response, or you want to consider them for heart transplantation due to worsening symptoms, that's a class 1 indication. And the second and only class 1 indication is for evaluation of unexplained dyspnea. So a cause of shortness of breath that you're unable with your initial testing to home in on, you would order a cardiopulmonary exercise test. All right, so let me bring up my mouse. See, okay. So now I want you guys to look at this figure, okay? So consider this, the left ventricle. Can you see that? The right ventricle, arterial circulation, venous circulation, muscles, and lungs, just as a schematic representation, all right? So in order for you to perform well in a cardiopulmonary exercise test, or in general to be functional, you have to have good oxygen through the lungs that comes in through the pulmonary veins into the heart, into the left ventricle, gets pumped forward. The 2 numbers you need to know within the lungs are PET O2, which is end-tidal O2, and PET CO2, which is end-tidal CO2. This PE end-tidal CO2 is a surrogate of arterial PaCO2. That is an important thing to remember. So oxygenated blood comes from the lungs into the heart, is pumped forward in towards the muscles. So these are the numbers that you would use in the arterial circulation. These are typically measured by an ABG, PaO2, oxygen, arterial oxygen content, SaO2, which is the saturation of oxygen that you can use using a pulse ox, and PaCO2. Oxygenated blood will get into the skeletal muscles, but here it has to be taken up in order to be utilized for production of energy. That's what we call VO2, or oxygen uptake. As a result of oxygen uptake and metabolism and energy production, your byproduct is CO2, carbon dioxide is produced, and vSO2 represents CO2 production. Then that will go through the venous circulation into the right side of the heart, and this is where you come up with these numbers. So this is your saturation, SVO2, that you typically use. You guys know what this is. This is mixed venous oxygen saturation. Actual mixed venous oxygen content, C stands for that, and the partial pressure of oxygen in the venous circulation is PVO2. Then it goes to the lungs again, and gas exchange has to occur, and then it's a cycle that continues. The major equation you need to understand is the Fick equation, right? So if you look up here, cardiac output is equal to oxygen consumption over the O2 content difference between the arterial and venous circulation. If you re-put this, oxygen consumption, which we measure via CPET, is equal to cardiac output times the differential, AV differential of oxygen content, all right? Now, this is an important point to remember. In normal subjects and people who are diseased, that have cardiopulmonary disease, typically, in particular cardiac disease, at peak exercise, they will extract about 80%. So the differential AO2 minus VO2, they will extract 80% of oxygen. So assuming you're 100% here, you would be 20% at peak exercise. And this relationship does not change between normal subjects and disease subjects. That is why we can use oxygen consumption as a surrogate of cardiac output, okay? Now, while I'm saying that, let's just look at the oxygen content equation, arterial and venous. One important parameter that you see here is the hemoglobin as well as the oxygen saturation, all right? That means if you're anemic, because this I want to tell you off the bat, that means if you are anemic, then using this FIC equation, if you're going to use VO2 to estimate a cardiac output in a patient using a cardiopulmonary exercise test who's anemic, say hemoglobin of 7, you are going to underestimate the cardiac output because the hemoglobin is low, so this number will be low and your cardiac VO2 will be low as a result of that. So the patient may actually have a normal, or you guys know really well in anemic patients, you actually have high cardiac output, but if you did a cardiopulmonary exercise test on them, their peak VO2 will be low. So it has to be in the context of knowing what the hemoglobin is, all right? Now, just going over where the problems can occur. So VO2 and cardiac output can also be written as heart rate times stroke volume, that equals cardiac output, times the arterial venous oxygen content. Let's start from the right. So the venous oxygen content may be different if you're not utilizing oxygen in the periphery. So I showed you that figure where oxygenated blood gets into the skeletal muscles. But assume there's a myopathy, a mitochondrial myopathy, and you cannot utilize the oxygen. Well, what's going to happen is your CVO2 coming out into the venous circulation will be high. Something like you see in sepsis. Your oxygen utilization will be poor, and hence this number will be low, and your peak VO2 is just low because you're unable to extract oxygen at the skeletal muscle level. Is that clear? That part clear? Anybody can just say.
Yes.
Okay. Now let's look on the arterial oxygen content. So what do you need to oxygenate the arterial blood that then passes through the left ventricle? Well, your hemoglobin, because hemoglobin is what carries oxygen, has to be normal. Your PaO2, that means if you're hypoxic for some reason to begin with, all right, for example, you have a shunt, you have an intracardiac shunt, and you are having a right to left shunt, like in congenital heart disease. Your PaO2 will be low, hence the amount of oxygen available to extract will be low, and your peak VO2 will be low just because of that. So there are situations where if this is abnormal, will alter your VO2 cardiac output relationship, okay? Now, heart rate and stroke volume is simple, right? Stroke volume is going to be low in heart failure or cardiac disease. Heart rate can be low in chronotropic incompetence, whether it's from sinus node dysfunction or you've actually blocked with, say, beta blockers. So your peak VO2 can be low if your heart rate doesn't augment with exercise, if your stroke volume doesn't augment with exercise, or if there is some major difference in your arterial venous oxygen content beyond normal physiology. And that I gave you some examples, like if you have a muscle myopathy or if you're anemic, mainly, those are the main ones to remember. Now, what variables do you measure during cardiopulmonary exercise testing? And this is what we're going to go over in some detail. Work rate. Let me tell you very clearly, there's two ways of doing cardiopulmonary exercise tests. You can either use a treadmill or you can use a cycle ergometer. Most programs have moved towards cycle ergometer. Having said that, that is not the case for all programs, but the reason for that is that when you have a cycle ergometer, you set the work rate. So you have like a 10-watt increment per minute. So you can actually precisely calculate work rate as long as they're cycling at the set RPM. Is usually between 55 to 65 RPM. You want them to cycle at that speed. And if they cycle between that range, you know they're doing 10 watts of work every minute. So as the increment goes up, if they peak at 100 watts, you know they have done 100 watts of work. It's important because when you look at the relationships. So what are the metabolic parameters you can use with CPET? In very simple terms, people who are not familiar with CPET, all you're really measuring with the CPET and the oxygen, the mask that you put on, is it's basically a sensor. It's measuring your oxygen uptake. The way it does that is knows the ambient air is FiO2 of 21%, and it just measures the percentage of FiO2 in the exhaled air, and it just subtracts the difference and makes it oxygen uptake. And then it just detects how much carbon dioxide is being exhaled, when you're during expiration. So it's just measuring those two parameters, and then when it multiplies by the frequency and tidal volume, it can tell you the maximum minute ventilation. But really, all that it is that it's doing. The other things is that actually the ECG electrodes, you have an ECG that monitors the heart rate, you have a blood pressure cuff that measures the blood pressure response. We'll go over those in a bit, but it's not very, all of the metabolic parameters that we look at CPET are derived from those simple gas measurements, all right? So it's like some magical thing. I mean, it just measures very basic things. So the things we need to go over: what is peak VO2? VCO2, I already showed you, is the carbon dioxide production. RER is known as the respiratory exchange ratio. It is a marker of, basically, I'll explain that in just a moment here, but it tells you if the RER is above a particular number, it tells you if it was a good effort or not, but there are other things that the RER tells you, so we'll go over that. Anaerobic threshold, I need to explain that in a moment. Heart rate recovery, and heart rate recovery is basically when the patient stops exercising, you see what their peak heart rate was, and then at 1 minute, you see what their heart rate was, okay? So a normal recovery in at least 20 to 30 beat per minute, 20. But if it's less than 12, the decrement is less than 12, that's considered an abnormal heart rate recovery. You look at the ECG in particular for use arrhythmias and ST depressions, that will give you a diagnosis that it's a cardiac limit. Blood pressure responds to increases with exercise, and your diastolic blood pressure should remain the same, and or at times, if you have good compliance, it should decrease. O2 pulse, we'll go over that. In the respiratory, I told you VE means total ventilation, minute ventilation. VT means tidal volume, how much in and out, or how much you're inhaling at a particular, with each breath. VR is called ventilatory reserve. That is a very important thing that we have to look at. End-tidal O2 and end-tidal CO2. I told you they are surrogates of, so end-tidal CO2 is a surrogate of your PaCO2, because we don't always measure arterial blood gases with CPET. Although a lot of centers do that, they put in an arterial line, and every 2 minutes they take an ABG. We typically don't do that here, but it is done in particular circumstances. The next one is you measure the oxygen saturation, and then you look at a ratio of minute ventilation to VCO2 that is called VE-VCO2. There's also another ratio with VO2 called VE-VO2. It's not that important in terms of interpreting a cardiopulmonary exercise test. So if you do an ABG, you can measure lactate levels, and when the lactates start rising, you know you have hit anaerobic threshold, which that is called AT, or lactate threshold. We will look at that. You can also measure the saturation of oxygen, more precisely PaO2, PaCO2, and very importantly, ABG is the only way you can measure dead space ventilation, and this will VD upon VT. This is the only accurate way of measuring VD upon VT is using an ABG. I will show you the equation, but I can tell you that modern day CPETs use end-tidal PCO2 to estimate VD upon VT. Having said that, honestly, you can't really do that. If you really want to measure VD upon VT, you should do an arterial blood gas. And then symptoms are very important. I'll tell you why. Most patients who have cardiac limitation stop exercise due to leg fatigue. It's not due to dyspnea, actually. Ventilatory limitation, predominantly they stop due to shortness of breath. And chest pain, as you know, that is a marker of ischemia, myocardial ischemia, so that's also important to know. So a peak VO2 and VO2 max, the difference is as follows. If you see a plateau at the end of exercise, that is VO2 max. If you just see that the patient terminates exercise and you're not sure if they really plateaued, if they've gone higher, you call it peak VO2. It's just terminology. You understand the difference now, but it doesn't really make a difference because that's the maximum the patient could perform. So Oxygen uptake is the best available index for assessment of exercise capacity. It is by far the most important variable we measure using CPET. You know its max when the plateau is achieved and you see the plateau. I showed you an example. Otherwise, you just measure VO2 at max exercise. In general, I'm giving you some general, so try to understand these. In general, above 80% predicted. Now, how do you predict someone's VO2? You base it off their age, gender, height. Weight adjustment has been kind of favored out. So basically, you measure greater than 80% predicted is normal. Less than 80% predicted is abnormal. And let me give you some absolute numbers. If your peak VO2 is over 20, for any age group, it is unlikely that there's some serious underlying cardiopulmonary pathology. 15 to 20 is definitely impaired, but it's considered mild impairment. When you drop below 15, it's considered moderate impairment. And when you drop below 10 or 12, the ranges differ, is basically severe impairment of exercise capacity or peak VO2. You know, trained athletes like myself can achieve like 80 mLs per kilogram per minute. And then, you know, there are some people that can't even do 20 ml, like some of our fellows. So anaerobic threshold is what does it mean? That's the first thing. So I told you that arterial blood goes into the skeletal muscles. There's uptake of oxygen. This is aerobic metabolism. Then there comes a time when the heart just cannot pump more blood, enough blood to keep up with the metabolic demands. As your work rate increases and you're exercising more and more, the heart just cannot keep up with the oxygen delivery to the skeletal muscles. Then what starts happening is you start shifting from aerobic to anaerobic metabolism. And once you start doing that, you start developing some lactic acidosis, all right? Now, when there is lactic acidosis, the initial buffer that is present in tissues is bicarb. So bicarb buffers lactic acid, and the byproduct of that is CO2 and water. So that means that the initial carbon dioxide production was from aerobic metabolism. Now there is additional CO2 production as a result of buffering the lactic acid production. Once the VCO2 increases, this increases your minute ventilation. Your minute ventilation goes up significantly after you reach anaerobic threshold. I will show you that in the form of the plots in just a moment. So why? Because it has to get rid of CO2 to normalize the pH. It never is able to normalize the pH. You still have metabolic acidosis to some degree at the end of exercise if you use an ABG to measure it. But that's a compensatory mechanism, all right? Now, anaerobic threshold is a very important number that you should be able to pick up where it occurs, because the normal people will have, or normal people or people who, well, we'll talk about athletes and elderly, but normal people will develop an anaerobic threshold, also known as ventilatory threshold. Some people also call it the lactate threshold, at around halfway point for their peak VO2, or around 2/3, 50 to one half to 2/3 away into their exercise, they will hit this ventilatory anaerobic threshold, okay? If you hit this early anaerobic threshold early, like less than 40% of the total exercise, that is abnormal. What does that mean? It means that very early on during exercise, your heart is giving up and it's not able to deliver the oxygen to the skeletal muscles. So less than 40%, if you hit anaerobic threshold, is a marker of cardiac limitation. I hope that's clear. Now, how can you figure it out? So these are curves. When we go to the 9-panel display, that Wasserman 9-panel display, I'll show you where these are. But on the left, there's VCO2, which is your carbon dioxide production, and this is your VO2. So there's something called the vslope method. So understand that this relationship is usually linear. But when you hit the anaerobic threshold, I just told you VCO2 production goes up, right? So you will see a shift in the slope of the VCO2 curve. So the VO2 will increase a little bit from thereafter, but the VCO2 will increase precipitously. So this right here, you see that this is one tangent, this is another tangent. There's a clear takeoff at this point. This is called the vslope method of detecting ventilatory thresholds. At this point, you bring it down. The VO2 was 1500 ml per minute, and say the total he did was 2.5 ml per minute, so that's fine. It was like 50%, a little less than 50%, okay? So that's how you detect anaerobic threshold. Now, this is minute ventilation. I told you VE is minute ventilation. This is carbon dioxide production. When you hit anaerobic threshold, you start hyperventilating to get rid of the CO2. So this minute ventilation is far more than what the CO2 production can be. So your minute ventilation will also, with regards to VCO2 production, take a steep curve. And at this point, this will be called the ventilatory threshold using VE, which is minute ventilation, or VCO2. The first one was using vslope method, which is VCO2 and VO2. This is using minute ventilation and VCO2. The third way you can do is using something called ventilatory equivalence. It will come next into it. It's basically the ratio of your minute ventilation to your CO2 production and your minute ventilation to your VO2 production. So again, let's think about this just a moment. This is where it occurs, but let me tell you what happens. So when you hit your anaerobic threshold, your minute ventilation will increase with regards to VCO2. I just showed you that, right? I just showed you that here. So what's going to happen here is starting at the ventilatory threshold, your VE to VCO2 ratio will go up because minute ventilation goes higher than VCO2, so this ratio will go up. So that's one thing that will happen. When your minute ventilation goes up, your oxygen, as in your VE to VO2 ratio, will also go up because your oxygen consumption at anaerobic threshold, you're not going to consume more. That's the reason why you switch to anaerobic metabolism, right? Right? That was the reason. Otherwise, if the oxygen uptake kept going in proportional to VE2, nothing will happen to the ratio. So minute ventilation increases, oxygen consumption remains the same because now you're kind of having anaerobic. It does go up a little bit, but you're still hitting anaerobic metabolism now, and your VE to VO2 ratio will also go up. Generally speaking, the VE to VO2, which is highlighted in red, goes up before VE VCO2, but this crossover point is roughly where the ventilatory threshold is occurring. And so you can just plot down from here. Here it's depicted in watts. So you can basically calculate at 120 watts what was the peak VO2, and that will be your peak VO2 at anaerobic threshold, okay? The next one is same concept. Once you start hyperventilating, your PET CO2 will start decreasing because your end-tidal CO2 will start decreasing because you're warding off CO2. And your PE end-tidal O2 will increase because you're hyperventilating and you're getting in more oxygen. So this point and this point, although there's a delay between them, is kind of, the first point is kind of where the ventilatory threshold will be, again, around 120 watts in this example. And so whatever the peak VO2 is at that example. The reason why I'm spending time on this is that a ventilatory threshold is an important thing to recognize, because if it happens, it's important where it happened. If it doesn't happen, it tells you very useful information as well. This is what a raw data would look like on a cardiopulmonary exercise test. It's just showing you the same takeoff. So VE VCO2 starts increasing precipitously here. So this is where where your anaerobic threshold is, and you'll just go and see what the VO2 was at that point, and you'll know what where the ventilatory threshold was. So you can use raw data, you can use PET O2, PET CO2 curves, you can use the ventilatory equivalent curves, you can use minute ventilation and VCO2 relationship, or you can use the vslope method, which is using VCO2 and VO2. Those is how you calculate anaerobic threshold. So the cardiac parameters. So what happens, cardiac output should increase linearly with VO2, and it should not vary depending upon training. Someone is saying something in the middle. Is there a question?
Yeah, quick question. Of the three methodologies that you showed, is there a reason to believe one is better than the other, or if there's a discrepancy, should we trust
Yeah.
more
Yeah.
than the other?
The reason why we use multiple checkpoints is because there's a lot of variability in interpretation of where the ventilatory threshold occurred. So the recommendation is the more you can look at least 3-4 variables, and if they concur with each other, or sometimes it happens 2 or 3 are in agreement and 1 is off, so you'll use the one that is more in agreement. So the idea is to use several, not one or the other, but the one most commonly used is the vslope method.
Imad, is it important to know this, where you meet anaerobic threshold to calculate the slope of VeVCO2?
So yes, because VeVCO2 slope can be measured. Most people and the prognostic studies of VeVCO2 were utilizing measuring the slope at anaerobic threshold, whereas other people who contest that say that you should measure VeVCO2 slope using the entire data points all the way to peak VO2 and average out and come up with an average number. So it is very important, if you want to know VeVCO2 slope, if you're measuring it at anaerobic threshold, that you have to hit the anaerobic threshold. Yes, you have to be very sure, at least in the vicinity. You should be very close to the vicinity of where it is, right? Okay, so as you start exercising, the initial thing that increases is your cardiac output initially increases by both the combination of your stroke volume increasing and your heart rate increasing. But around anaerobic threshold, or a little after, it is exclusively heart rate increase that is augmenting the cardiac output, okay? The other important thing is, what is your maximum heart rate? Everyone knows that. Most people use this 220 minus age. And if you reach above 85% of that predicted heart rate, it means you have reached your heart rate reserve. In general, that's how we use this. Heart rate recovery, I told you that if your heart rate recovers less than 12 beats per minute in a minute, at 1 minute, the difference is that it has only come down by 12 beats from peak to 1 minute. That is a very abnormal heart rate recovery. It is a very poor prognostic sign in not only in heart failure patients, but also CAD patients. So these are the cardiac, some of the cardiac parameters. So peak VO2, heart rate, and heart rate reserve, heart rate recovery, those 3 things. The other thing is O2 pulse, very important variable that we measure. So remember I told you that VO2 equals cardiac output? So cardiac output is stroke volume times heart rate, right? So VO2, in other words, stroke volume is equal to VO2 over heart rate. So in other words, VO2 over heart rate, which is the O2 pulse, is a representation in vast majority of cases, although there's some exceptions, but I don't want to confuse you, because initially we're learning interpretation. VO2 over heart rate is a surrogate of stroke volume, okay? So it is the amount of oxygen extracted per heartbeat, and the normal, oh, I'm sorry, I don't have it here. It will come in the next table. The normal in women is about 10 ml per heartbeat. In men is about 15 ml per heartbeat. And an important number to remember for the absolute O2 pulse is that if you are less than 10 ml per heartbeat, that is a strong sign that you have your inability to augment your stroke volume with exercise, okay? So it will be a cardiac limitation sign if you have a O2 pulse that is low. I will talk about plateauing in just a moment here when I show you the O2 pulse curve. But sometimes what happens is early on during exercise, you have plateau of the O2 pulse curve. Usually it goes like this, but it kind of plateaus early. What it means is that with more excessive work rate and increasing exercise, your stroke volume is not augmenting. Only way you're augmenting your peak VO2 is because you are increasing your heart rate. So if you have early plateauing of your O2 pulse curve, that means very early on, you cannot further support the cardiac output with increasing exercise using your stroke volume. And that is another sign of cardiac output limitation. Blood pressure response, I sort of told you. If your blood pressure declines with exercise, that is a very abnormal sign. As first of all, you should stop it is an indication to terminate the test. That's your patient can pass out. And it's a very poor prognostic sign and almost always due to cardiac limitation although sometimes it's related to autonomic failure, which is a rare condition, but it's predominantly cardiac limitation. Now, for pulmonary parameters that you can look at are ventilatory reserve. So the first thing you need to know is what is maximum voluntary ventilation. Maximum voluntary ventilation can either be estimated, and the way to estimate is, so by the way, guys, if you don't do cardiopulmonary exercise testing, or if you don't know what's done in the lab, the first thing that is done before even you start the cardiopulmonary exercise test is a spirometry. They do FEV1, FVC, and you can use your FEV1, your forced exhale volume in 1 second, times 40 to calculate the maximum voluntary ventilation. So this means that if you really push the patient to their limit, that is the maximum amount of ventilation they could do, is maximum voluntary ventilation. Or you could, if you don't want to estimate it, FEV1 times 40, you can actually measure it. So what do? You tell a patient that for 15 seconds, they have to take deep breaths in and out as fast as they can. All right, as deep as they can breathe in and out as fast as they can in 15 seconds, and you multiply by 4 and give you their liters per minute of maximum voluntary ventilation. Okay, why is that important? So guys, if you have a pulmonary limitation to exercise, say you have COPD, that means you, at the end of, when you reach the end of your exercise and you have a peak VO2, it's typically going to be low, but it's low because of pulmonary limitation, not because the heart wasn't able to augment cardiac output. So one of the signs is that you do not have a ventilatory reserve. In other words, say your maximum voluntary ventilation was 80 liters per minute. At peak VO2, you had already achieved 80 liters per minute. Now, this is very different in a patient who is normal. Normal people have at least 30% of their breathing reserve at peak exercise. So normal people are never limited by their ventilatory reserve, never. They're always limited by their heart. So what happens is, as you all know, we have a maximum heart rate. I mean, you can estimate it 220 minus age, but I will never be able to get my heart rate over, say, 165, depending upon my age. And so if I stop exercising, it will always be because of a cardiac limitation. Normal people stop exercising because of cardiac limitation, not because of pulmonary limitation. So at whatever the maximum normal people can give, they will still have a breathing reserve of at least 20%, but ideally 30%. Does that make sense? In cardiac limitation, your heart will limit you before your lungs. Your breathing reserve will be 30% or more, and definitely not less than 20%. 20 to 30% is that gray zone area. So it's a very important number. You can estimate it by FE1 times 40, or you can actually measure the maximum voluntary ventilation, and you will look at what number are you going to compare it with? The VE, the maximum ventilation, total ventilation at peak exercise. And then you'll compare the two numbers and you can come up with a ratio. All right? So this thing, I don't know, if you don't supervise CPATs or you don't do them, you may not know. But even at our program, but in other programs, it's pretty routine. But even in our program, at twice or 2 to 3 times during the CPAT, every 2 to 3 minutes, you're asked to take a deep breath in and breathe out. That is, you're basically trying to measure a flow volume loop. And so you can tell clues. I don't want to go into explaining this because we're going to get short of time. If we have time, I'll explain to you how to interpret flow volume loops. But this is normal on the left. And here you can see when the patient is exhaling, they have this concave shape. This is suggestive of obstruction. So during the exercise, you can actually pick up obstruction, airway obstruction. And if you pick that up, that is called dynamic airway obstruction. That means you have a pulmonary limitation to exercise. So routinely, you measure flow volume loops as you go along with exercise to look for pulmonary limitation to exercise, okay? Now, in some patients, this is just looking at the minute ventilation over work rate. Let me just tell you, just so that you guys know, some people, depending upon programs, some people look at watts, some people look at time on the x-axis. It doesn't really matter. It does not change the relationship of the variables you're looking at. So you guys see this ventilation increases over time to peak exercise, and then this is recovery. Look at this one, very abnormal, oscillating. This is called exercise oscillatory breathing, or EOB. If you see this, it's a very poor prognostic sign, and it's predominantly due to cardiac limitation, and it's a strong predictor of sudden cardiac death. So if you see this is a patient, regardless of what their other parameters are looking like, that this patient has a high risk of sudden cardiac death. He needs close attention. All right. This,
yeah, Imad.
Sir.
So I think, with EOV, especially in heart failure, it's been shown to anything more than 2 EOVs has been shown to be, predictive of mortality, and it's at least people think this is a reflection of awake chain strokes, or awake chain strokes during exercise.
So, yes, basically this is exactly what you see during sleep, something called central sleep apnea, in awake patients that have chain strokes breathing. And in exercise, this is also involuntary. They're not doing this on purpose. This is different from malingering, which I'll tell you, you can differentiate it. I may not have the time to show you how malingering looks like, but the point is that this should happen for at least 60% of the exercise. Sometimes what happens is patients are anxious when they start exercising, and you can see this, that they're hyperventilating initially, and then they're trying to adjust their breathing. So this should last for at least 60% of the total exercise time. And the variability should be, the amplitude of variability I'm showing you with my mouse should be at least 15%. Now, this is not universally agreed upon, but that is what most people agree upon, expert opinion. So then comes the ventilatory equivalent of CO2, what Ash was talking about, the VE-VCO2 slope. This, in a nutshell, is a marker. This measures ventilatory efficiency, all right? So it is looking at your minute ventilation over your carbon dioxide production, all right? It is a measure of ventilatory efficiency. Say this ratio is high. In the right setting, that could mean, and I'm going to explain to you in just a moment what it means. Hold on, let me tell you what it means. But first, let me tell you what is normal. Normal is 24 to 34, the number. If your number is over 34, it means that this is very abnormal. You have evidence of ventilatory inefficiency. What does ventilatory inefficiency mean? So ventilatory inefficiency basically means you have your lungs, right? When you're sitting upright, you have more perfusion to the lower lobes because of gravity, and you have more ventilation to the upper lobes. There's a ventilation perfusion mismatch at rest, okay? Now, as you exercise, what happens is as your cardiac output increases, more blood flow gets into the lungs, and these more capillaries in the apical zones are recruited. So initially what happens is your VE-VCO2 with exercise improves, the number decreases because your ventilatory efficiency is improving. In other words, the ventilatory inefficiency is less. But then as you hit anaerobic threshold, right? I told you what happens in anaerobic threshold is now you're switched to anaerobic metabolism. You have more VCO2 production. You have more VCO2 production, but that triggers your minute ventilation to go up. Your minute ventilation goes up more than your VCO2, so your VE-VCO2 in normal people at anaerobic threshold, I'm not talking about heart failure patients or pathological, in normal patients it will start going up. I showed you that in the curve when we were estimating anaerobic threshold. VE-VCO2 normally goes up. Now, what are some of the scenarios where what pumps blood to the lungs? It is the right ventricle, right? So say with exercise, you have heart failure or you have RV ischemia. For some reason, you're unable to augment your RV stroke volume. What happens? Well, what's going to happen is you're going to have decreased perfusion, but you have more ventilation because your minute ventilation goes up with exercise. Your VE-VCO2 will go abnormally high. And this is a marker of RV failure, right? Your RV is unable to get blood to the lungs to get oxygenated. On the other end, even ventilatory abnormalities. So if you have COPD and as your minute ventilation goes up, what happens is your frequency of breathing is increasing, right? So what can happen is you can start developing air trapping. So start developing air trapping, you're going to have more ventilation perfusion mismatch. And if that happens, again, the same thing will happen, is that your VE-VCO2 will go up So VE-VCO2 is not specific for, it is not specific for cardiac limitation, in a sense that it is not RV failure specific, but in the right context, it can tell you about RV performance. Okay, does that make sense so far? So this is your VE-VCO2 slope. This is VE-VCO2 slope. So up till anaerobic threshold, the relationship is linear. Then, like I told you, it goes up precipitously. So you can measure, if you measure at anaerobic threshold, these are showing you the various relationships. A VE-VCO2 of 63, I mean, that is a very high VE-VCO2 63. Typically, you will get that with someone who has like pulmonary vascular disease, like severe PAH, and the RV just cannot overcome this huge afterload, and hence it just cannot perfuse those areas of the lungs that are being ventilated, and your VE, you have huge amount of ventilatory inefficiency, and you have a VE-VCO2 that's very high. 34 is a cutoff. A VE-VCO2 of 34 in heart failure we use as a cutoff for a poor prognostic sign, independent of what your peak VO2 is. So what are the normal cardiac, let me just see what the time is. I'm trying to be detailed and trying to get you guys to understand these things, but I have a lot of content to cover, but let me just give you some other, let's just keep going and we'll see when we have to stop, and then I might have to continue at session number 2. But VO2, exercise can increase by up to 12 to 18 times. I'm talking about the normal cardiopulmonary responses. Heart rate increases about 2.5 to 3 times. You know what the maximum limit is, 220 minus 8. Stroke volume in general with exercise, maximum exercise at the most, we can go up by 2 times or 2.5 times in athletes. Cardiac output can augment as up to 4 to 5 times. So don't be surprised if someone has a exercise cardiac output of 25 liters per minute. And minute ventilation can go up by 20 to 25 times. It can go up quite precipitously. Okay, so let's just recap on some of the things. I told you that your O2 pulse, normal, in men is greater than 15 mLs per beat. In women is greater than 10 mLs per beat. But if your O2 pulse is less than 10 mLs per beat per minute, it is very abnormal. PET CO2 with exercise will decline, right? Once you hit ventilatory threshold, your minute ventilation will go up and your PET CO2 or end-tidal CO2 will start decreasing. Your end-tidal O2 will start increasing with ventilatory threshold. RER, respiratory exchange ratio, is just basically all it is VCO2 over VO2. As you know, once you hit anaerobic threshold, your VCO2 or your carbon dioxide production will go up. Your VO2 will remain relatively stable or slightly increasing. So your RER will go above 1. That ratio will go above 1. And inadequate effort will be considered when you have an RER of 1.15 or more. Okay? Oxygen saturation is usually above 95%, and it's considered abnormal if it drops more than 4% and it's sustained. In other words, once you stop exercising, it takes a while for your O2 sats to recover. That is considered true oxygen desaturation. Otherwise, sometimes what happens is you have a finger probe and you're just pressing hard on the handrail. And so if your O2 saturation recovers immediately when you stop exercising, that is actually artifactual. If it was true drop in oxygen saturation, it takes some time before it recovers. VD upon VT is a very important measure. I told you it is the dead space ventilation. So consider VD upon VT. Normal is 30%. 30% of your ventilation is dead space. How? You have the trachea, you have the bronchi, and then you have those unrecruited. I told you when you're sitting upright, you have part of the lungs that are underperfused. This is all dead space. When you're ventilating, it does not participate in gas exchange. Once you start exercising, your dead space ventilation should decrease. This ratio from 0.25 to 0.35 should decrease with exercise under normal circumstances, actually go down to somewhere around 10%. The way to measure that is in ABG. Like I told you, the metabolic cards modern day, they do estimate this for you, so you can look at the trend of it. If it say starts at 0.3 and ends at 0.1, you know that it's appropriately decreasing with exercise. But that's what exactly should happen when you exercise. Your dead space ventilation should improve, right? VD upon VT should come down. VE, VCO2, we already talked about. VO2 max, we already talked about. Okay. This is, if you do an ABG, this is how you calculate dead space fraction. PaCO2 minus PeCO2. All this is at the time of the ABG, what was the expired CO2, what was the VCO2 over the PaCO2, and we'll give you the VD to VT ratio. People who do ABGs, like I tell you, they do it every 2 to 3 minutes, and they do it at peak exercise, so they can tell if VD over VT is improving, which it should. And ABG may be very useful in there are circumstances when this doesn't improve, and that's what we're going to talk about. Okay, so first of all, I want to stop here because of these concepts, is there anything that you guys don't understand that I should go over again? Because now I'm going to go over how to use these CPET parameters to distinguish between patients. You know, because I can't look at the chat because I have full screen. If you want to say something, just just unmute yourself and say it. Otherwise, I will continue.
Dr. Hussain, quick question.
Yes, sir.
So the VE to VCO2 is not specific to cardiac limitations.
No.
But
no.
That you have an abnormal VE to VCO2 and your VO2 max is within the normal. Does that mean that you have a pulmonary limitation?
No, not necessarily, because you have to look at the other things. You could, like I said, it's an independent predictor of heart. Sometimes it is a cardiac limitation, but your peak VO2 is above the cutoffs that we use for, say, transplant listing. It's still a cardiac limitation to exercise. No, that is not the way you'll distinguish. We'll go over how to distinguish. But yes, the VE VCO2 is not at all specific for cardiac limitation. It is not at all, though. That's why I try to explain it. It's ventilatory inefficiency. The higher the number, the more ventilatory inefficiency you have. And all it means is that gas exchange is not occurring properly. In other words, you have more dead space for the ventilation. So that can be from pulmonary diseases, or you're not getting enough perfusion to the ventilated areas, and that is because of the predominantly RV performance at that point, which is a cardiac limitation. So
if I missed that, the RER, if it's low, does that mean the respiratory exchange ratio, if it's low, is not a usable study, or? Right.
If your RER is very low, it's an inadequate effort, but your RER can be low in a patient who gave it best effort in a pulmonary limitation circumstance, which I will have. That is why I'm going to go over these nuances. That is why it's important that you understand the core concepts, because the core concepts are not clear. Then once I start getting into the nuances of how to distinguish, you will not, you guys will not, carry forward.
Yeah.
So if this is clear, because I'm happy to spend a little bit more time on this and then go over this. Tracy is telling me my clinic starting at 2. Tracy, is that right? I can go a little over to go over some of these things, but in order for you guys to learn CPET well, you need to know the variables. You need to know how to interpret them. So I will come back to this differential of the patterns of limitation with cardiac, ventilatory, or if you have pulmonary, vascular, and ILD, they're plugged as to one because the patterns are distinctly different in these 3 types of abnormalities. But let me first show you what a Wasserman plot looks like. So this is the graphical display of a standard Wasserman plot. I told you that the x-axis, some programs use time and some programs use watts, the work rate, but it does not change the relationship. And so that is the only thing that's variable. Otherwise, this is a pretty standard display of what's going to be shown on it, but the x-axis can be different. That's why I keep wanting to point out it can be time or it can be watts, like here. All right. Now let's just go over this real quick, and I think that you need to understand what they're showing, okay? So the first one on the left, if I can get my mouse, okay, is just looking at minute ventilation over time or using work rate, which is telling you the same thing, just time is passing by or workload is increasing. Your minute ventilation in normal people will increase steadily throughout the exercise, all right? But it will never reach what? Breathing reserve. It will be at least 20 to 30% below the breathing reserve calculated using the MVV, which is the maximum voluntary ventilation. The next to your left is two things. The VO2 over heart rate. You remember I told you this is a marker of stroke volume. This absolute number, this is where you'll see the y-axis should be over 10 at least. For men, it should be even over 15. And then if you see an early plateau, what I mean is that it will come like this, it'll plateau and it won't increase with exercise. This is how you look at the O2 pulse. It's usually in the middle panel of your 9-panel display. The black line is the heart rate. So this panel shows heart rate and VO2 over heart rate. Heart rate should steadily increase towards exercise, and then it will plateau when you reach your maximum heart rate. So that's simple. The third one on the top row is your VeO2 and VeVCO2 relationship. This is what Ash was talking about, so at anaerobic threshold, so you see this VeCO2, basically there's a takeoff here. This is your ventilatory threshold. Right here is your ventilatory threshold. And so here at anaerobic threshold, you can calculate a slope. That will be your VeVCO2 slope. And that is measured by the machine. And then your VeVO2 relationship. So when they cross, as I showed you, you can get some idea of where the anaerobic threshold is. The next one is your VE to VCO2 relationship. You can also use this as a measure of where the anaerobic threshold occurs, because once you hit anaerobic threshold, your minute ventilation will increase out of proportion to what CO2 production is. And you'll start, so say this is here. So around this part, it's the gradient increases. So this would be kind of your ventilatory threshold. The next one is your VCO2 to VO2 relationship. That is where you calculate the vslope method. So you'll have a tangent drawn here, and we'll give you, I'll give you your VeVCO2 relationship. Under normal people, their VeVCO2, I told you, initially decreases. As you can see, it's the black line, which is VeVCO2. Initially, your ventilatory efficiency improves. I showed you how, right? I said that it recruits the alveoli that are in the upper part of the lungs. And then once you start hitting anaerobic threshold, your minute ventilation goes up precipitously and your VCO2 will not be able to keep up. And in normal people, this relationship is that it improves. So VeVCO2 increases and VeVO2 increases as normal people at ventilatory threshold. The tidal volume increases steadily and then try to sort of plateaus or out around your around 60% of the exercise. Beyond that is just respiratory rate that is increasing your minute ventilation. So that is the tidal volume relationship. This is your RER, Mon. So if your RER, this is your 1. Once you hit anaerobic threshold, your VCO2 production will exceed your VO2. And so this is when your RER will exceed 1. And if you increase, this is when you know the patient has made an adequate effort. And also it's a signal telling you that the patient hit anaerobic threshold. So this is your RER relationship. It will always be in the bottom corner of your graphic display in the middle. And then the last one usually is the PET O2, end-tidal O2, and end-tidal CO2 relationship. And in normal people, the end-tidal CO2 should increase because once your minute ventilation increases, you will ward off more carbon dioxide and your end-tidal CO2 will start going up. So this is what a normal Wasserman 9-panel display looks like. All right, so this is where you look for your information. So in a cardiac limitation, pulmonary limitation, and pulmonary vascular disease and ILD pattern. Okay, so let's go over this. Now we'll go over back to the table. So let's go in terms of the cardiac output limitation. If you are limited by your heart, well, the first thing is, generally speaking, your blood pressure will rise. But if your blood pressure drops, that is a very poor prognostic sign. Your VD to VT, I just told you in normal people or people with cardiac limitation, your VD to VT should decrease because you recruit more alveoli, pulmonary capillaries in the alveoli, and your dead space ventilation will decrease. So in cardiac, VD to VT should decrease. Heart rate reserve depends. If you're on beta blockers, a lot of our heart failure patients, CAD patients are on beta blockers, they may not reach their heart rate reserve. They may not reach the 85% of peak heart rate because they have because they are on beta blockers. Otherwise, they should reach their heart rate reserve. Metabolic acidosis is present. What does that mean? That means that you have to hit anaerobic threshold. I will tell you how to differentiate that from a ventilatory limitation where you may not hit anaerobic threshold. But you have to find anaerobic threshold. If you're going to say this patient is limited by their heart, you should be able to see a ventilatory threshold. And typically it is less than 4. If they're limited by their heart, it is less than 40% of their total peak VO2. All right. O2 pulse. You will see an early plateau that I showed you in the last curve. Maybe I can show it to you here. This is cardiac limitation. So this is normal. The dotted line is normal. You can see that the O2 pulse, the absolute value is less, and there's an early plateau suggesting cardiac output limitation. So O2 pulse, you look at the absolute number and you look for early plateau. There should not be desaturation if there's a cardiac limitation to exercise. Your oxygen saturation should remain normal. Your PET CO2 should decrease just like it should in normal people. And predominantly you stop because of leg fatigue. Now it's not always the case, but in cardiac output limitation, the main reason usually for stopping is leg fatigue. The RER should be over 1.1, and the VE/VCO2 is usually increased, but doesn't have to be. And this is where you will differentiate. So ventilatory reserve, I told you that if you have pulmonary limitation, your ventilatory reserve, you will reach your ventilatory reserve. But in cardiac limitation, you will not reach that. You will have a good 30–40% ventilatory reserve. So if you have a good ventilatory reserve and you're seeing low peak VO2, which is always decreased, like peak VO2 is decreased, you have a ventilatory threshold, you can find one and it's low, and you have an O2 pulse that is low, and you have an early plateau, and your RER is over 1.1, and your VE/VCO2 is up, this will be what? Cardiac limitation to exercise. All right. Now, before I go into the middle one, because that is the confusing one, let's go to ventilatory. So what do I mean by ventilatory limitation? What I mean by ventilatory limitation is not gas exchange. So it means more like COPD, airway obstruction. If you have airway obstruction, what will happen? So sometimes your dead space ventilation with exercise may not decrease, right? Because of the increasing dead space when you have COPD and you're having dynamic airway obstruction. Heart rate reserve is large. What do you mean by that? What I mean by that is, in a ventilatory limitation, by definition, you're saying that the patient is limited by their lung well before their heart gets out. So in other words, their heart rate reserve will be pretty good. So if maximum heart rate is calculated 165, you have a pulmonary limitation, you hit 120. You have a good heart rate reserve, but you stopped exercising, your peak VO2 will obviously low. But here, the ventilatory reserve will be small. They will almost get all the way, their minute ventilation will be almost all the way up to their maximum voluntary ventilation, all right? Because of it's a ventilatory limitation, they will have ventilatory inefficiency, and their VE/VCO2 will also be high. Now, let me tell you one important concept that may help us differentiate pulmonary from cardiac limitation. I remember I told you anaerobic threshold. So in order to hit anaerobic threshold, it means that your heart can no longer deliver oxygen to your working skeletal muscles, right? But in a ventilatory limitation, the heart is not the limitation. So the heart continues to provide adequate oxygen delivery to the skeletal muscles. But your ventilation is giving out, and you're stopping because of shortness of breath. It's not because you have reached anaerobic metabolism. So in other words, if you do not see a ventilatory threshold and your breathing reserve is very low, it is almost always a pulmonary limitation. So if you don't see a clear anaerobic threshold, that means in a setting of a low breathing reserve, that means you have a ventilatory limitation to exercise. That by definition. Now, this is one scenario where Mon asked a question that RER usually exceeds 1.15, and if it's less than that, we say it's an inadequate effort. But in this case, the patient's not doing an inadequate effort. He's huffing and puffing. He just can't do anymore because his minute ventilation just can't keep up. He has a ventilatory limitation. He has reached his maximum voluntary ventilation, but he still has not hit anaerobic metabolism because the heart is doing well. It's able to deliver the oxygen into the skeletal muscles. So RER, you know, goes above 1 when your VCO2 goes over your VO2, because that's what RER is. RER is VCO2 over VO2. So if you're not hitting that, your RER can be 1 or less. So if you're not hitting anaerobic threshold, your RER can be less than 1. So this is one scenario where it is an adequate effort, but the RER is low because the patient just can't keep up with exercise because they have a ventilatory limitation. And lastly, which is obviously a giveaway, if you start having oxygen desaturation with exercise that takes a minute or two to recover or requires supplemental oxygen in the recovery, that is obviously a sign of pulmonary limitation. All right. Pulmonary vascular and ILD is a pattern that is combined together because they predominantly affect gas exchange. That is the first thing to know. What is the important thing here? The important thing here is that with pulmonary vascular disease, it is going to be a combination of cardiac and pulmonary limitation. How? The first thing, let's go to the O2 pulse. As you guys remember, the O2 pulse is a measure of stroke volume. So if the RV can't augment cardiac output with exercise because of an increased afterload in a setting of pulmonary vascular disease, what will happen to your O2 pulse? It will be plateau. You'll see the same plateau and decrease like you will see in a cardiac limitation, because it is a cardiac limitation. It is an RV that is unable to augment cardiac output. What is the other thing that overlaps? Well, peak VO2 will be low in all, but the other thing that would overlap is patients with pulmonary hypertension, they cannot augment their RV stroke volume, I just told you, with O2 pulse. So how are they going to increase their cardiac output with exercise? The only way they're going to do it is if they're going to augment their heart rate, right? Because that's the only way you can do it. If you can't augment stroke volume, you have to augment heart rate. So their heart rate reserve is low. So in other words, they will reach their peak heart rate, just like cardiac limitation, but the ventilatory COPD type obstructive lung disease won't. They will have a large heart rate reserve. So low heart rate reserve, low O2 pulse, these are markers of cardiac limitation, which is true in the case of pulmonary vascular disease, right? Because of the RV performance. The ventilatory reserve, although, will be small because these patients have a pulmonary limitation as well to exercise because they can't exchange gas, especially with ILD. And you will see O2 desaturation with exercise. So here, may decrease. You can see O2 desaturation with exercise. If you see a constellation of these 3-4 things, and I gave you an extra clue that the VE-VCO2 marker of ventilatory inefficiency is very high in this population. So if you see a VE-VCO2 of 60, it is usually not related to COPD, asthma, or cardiac output limitation. Is usually related to either pulmonary hypertension with the RV unable to get blood flow to the alveoli, or interstitial lung disease, but primarily pulmonary hypertension, okay? So a pulmonary vascular disease ILD pattern will be a mixture of cardiac and ventilatory. It will be a combination of the two. What is the third thing that occurs? The VD upon VT. I told you you can use an ABG to measure this. I showed you the equation. This is the equation. If your VD to VT does not decrease with exercise, yet you're seeing some other parameters that show cardiac output limitation like low O2 pulse, that is diagnostic of pulmonary vascular disease, all right? So ABG is very helpful to pick up this type of patients. Now, to differentiate between pulmonary vascular disease and ILD just needs a chest CT. I mean, when you're looking at CPET, you're just basically looking at patterns. You're not like getting down to the minute diagnosis. You're trying to give a pattern. So I want to stop here, but I want to make sure up till now, you guys have understood everything and the nuances of what you can look at to differentiate one thing versus the other. I would rather answer some questions related to that right now than try to go into examples when we've already exceeded our time by 12 minutes. And I apologize, it's on me for having done that. I should have been more efficient, but I really wanted to make sure you understood these things. So guys, first let's ask questions about what you did not understand or how I can help you understand these parameters. Because next week, I'm gonna show you real CPETs. The CPETs like you're gonna see them. They're gonna come to you like that. And probably probe some of you to try to start figuring it out. But in the end, I will help you try to come to the conclusions for what they are. But I want you to understand, what have you not understood, guys, amongst this? Sorry. Questions?
Dr. Hussain, I have a question. Can you please explain one more time why in pulmonary vascular disease the VD-VT ratio remains stable or even increased?
Yes. So, okay, look, the things that I cannot change because human physiology is the trachea, the bronchi, there always will be dead space, right? Normal people have 30% dead space, but all of that is not because of the big airways. It's some of them because the alveoli are ventilated, like the ones on the apexes of the lungs bilaterally, they're ventilated, but the pulmonary capillaries that are participating in gas exchange are collapsed, for lack of a better word, because of the gravity pull. Most of your perfusion is in the bases. So you have a VD upon VT, roughly about 30%. Now you start exercising. As you improve cardiac output, you'll have more flow to the lungs, and you will recruit these capillaries that were collapsed, and your VD to VT will improve. In other words, you will have less dead space fraction, right? You'll never have zero because you still have those airways that don't have alveoli, but your dead space ventilation or VD to VT ratio will decrease, right? In normal people. Now in pulmonary vascular disease, just imagine you have severe pulmonary hypertension, right? So there's not these pulmonary capillaries in the areas of the apices and mid zones, they're not well perfused. They're just not getting the blood flow. And because they're not getting the blood flow, that dead space that will still be dead space ventilation. Even though you're exercising, they're not improving. Your VD to VT will not improve because you can't improve the perfusion to those areas because your RV can't uphold this afterload. Does that make sense?
Yes, thank you.
Okay. So the way to prove this, like I said, you can look at the trends on a CPEX machine. It will tell you VD to VT with exercise. It will give you the whole sort of table. But the real way is to do an ABG. And a lot of programs like Mass General, they do ABGs as a like standard. Okay, guys, did you understand ventilatory reserve? Did you understand how to differentiate? Do you understand what I mean by overlapping pattern in pulmonary vascular disease / ILD? Does that make sense?
Yes.
Okay. So if I were to show you guys a CPET, I think the first example we'll do, I don't have time today, it looks like, unless you guys want to stay, I can go over one example and show you how to navigate the numbers. If you want, we can do one example, but you have to let me know. But otherwise, I will start with case examples and real life next week.